So good afternoon. So I would be talking about the understanding the sources of immunogenicity. I think we have a little bit of overlap with all the speakers, but that's justifiable because we cannot be really on the borderlines. So I would be especially discussing about what kind of sources we can have which can cause immunogenicity. So okay, so we have been trying to understand immunogenicity since last couple of years, and this is our content. I would definitely like to acknowledge all of them, and I would like to acknowledge especially, am I audible? My internet connection says unstable.
Yes,
Yes,
audible.
You're audible, Ashish.
You're audible.
Okay. So I would especially would like to acknowledge couple of two of my residents who have done phenomenal work with me since last 2 years and helped us with understanding this phenomena in great detail, Dr. Nilesh Kumar and Dr. Nicola Parachuri. So these are my financial disclosures, and regarding the sources, there could be a few things. For example, procedure related, syringe related, and if you talk about the drug per se, you can have endotoxin, molecule itself, or probably both. Procedure related means, I think since last 10 years, we have been giving intravitreal injections. So we know that what kind of injection settings are safe and what kind of injection settings are unsafe. And as Raja mentioned, bevacizumab was blamed not because of the drug, but because aliquot process was a problem. So in developing countries, this was predominantly an issue. It still is an issue, but not in the developed world. If we talk about the syringe related, this is the editorial that we published last couple of years before, when Allergan had done a temporary stop on the Ozurdex injection because they found during their R&D there was some particles seen. Although silicone doesn't cause immunogenic reaction, but because it was seen, so it was noted. And when we went back, this phenomena was there for quite some time. And Dr. Bailey Froon, he noticed it when it was noticed first time with the syringes. So we brought down this again, and what has happened was this could be related to few things. For example, silicone coating on the syringe and the needle, which is required for the smooth plunger movement and to make the procedure painless. And there is a possible interaction of biologics with the coating, along with sometimes we tap on the syringe too much, and if the silicone can disappear. It doesn't cause immunogenicity per se, but it causes floaters, unnecessary floaters. Now, what is the way forward? Now you have non-siliconized syringes available, especially in the developed world, but because of the poor cost effectiveness, they are not really universal as a siliconized syringe as of now. Then I would come to the drug-related complication. This is the paper that we published, as Raja mentioned, initially with few batches, Razumab showed reaction. And the reaction, when they went back and tried to understand that why they had those reactions, then they found that it was the problem of endotoxin levels. And the endotoxin levels was pretty high. And actually, if you look at the FDA do not differentiate anterior and the posterior chamber endotoxin limits. Anterior chamber, so whatever we do in ophthalmology setting, it's all about the endotoxin in the anterior chamber. So there is no clear recommendations of the posterior chamber endotoxin limit. So once they reduce the endotoxin limit, and the reason was the buffer. So whenever you have an endotoxin phenomena, then you have immediate immunogenic response, which was seen with Razumab. And these are the issues which are predominantly related to the excipient or the process. And this problem of endotoxin can be controlled, which was done by Intas, and over the time they have no immunogenic issues. So These are a couple of papers we highlighted that what we think about the endotoxin and how it affects, and there is an inherent tendency of any biologics, to have this because of the complicated process of manufacturing. Now, these are a couple of papers that we published when brolucizumab was launched, because brolucizumab, Novartis has done their homework, and Novartis has clearly mentioned that their processes are fine. There is no excipient issue. There are no preservative issue. So at the end, it bottles down to the molecule itself. So probably still things are very much in gray. Still Novartis has no clue that why that is happening. So the blame goes to the molecular structure as far as we understood this phenomena. Difficult to control. And these are a couple of papers, even when the Hawk and Harrier data published, we had a few questions about the design and the comparison. And once the brolucizumab had some signals in even Hawk and Harrier regarding the higher rate of IOI, that also we mentioned in these couple of papers. We got good response, to our satisfaction by Praveen Dugal in terms of the comparison, but still everybody is gray in terms of the immunogenicity aspect. So again, as I told you, this is the recent editorial that we published, that whether it's really a complex phenomena or we have something we can easily understand. As of now, our stand is that it is an ADA, which was found, even in the pre-injections in Hawk and Harrier. So ADA and the type 3, still difficult to understand and difficult to predict whenever it comes to the molecular related immunogenicity. Now, we have been tracking even abicipar since quite some time, and these are the couple of papers that we published even when abicipar passed before in ophthalmology. We had few questions in terms of how the immunogenicity assessment was done. So this is abicipar was a molecule which was not exactly the classical anti-VEGF platform, but rather it was kind of a DARPin platform, which is slightly different. So here the culprit was the E. coli fragments, because E. coli was used in their process. So initially they had a lot of fragments, but even after filtering the fragments, their immunogenicity was pretty high. So so here both endotoxin and the molecule per se had issue. Am I audible?
Yes, Ashish.
Okay, so means I really like to thank all my residents, and this is our wall. This is an innovation wall, and all these small chapters on immunogenicity understanding. I would really like to thank all my residents, who have put up a lot of efforts and published this data. And each and every frame, in my institute, it tells about their hard work, and they still dream and they keep dreaming. Thank you so much.